one thing I've been asking, or I've been thinking a lot about, Kevin, and one thing that my patients have asked me a lot about is, how, if we're on the injectable medication, I don't want to be on this for all my life.
Right.
And we don't have any long-term data to talk about ramifications of GLP-1s like you talked about. So this seems like a really fantastic way to, one, get away from needles, but two, I guess it would naturally seem like this would be a natural, or the next step.
It's been a big part of our conversations naturally as compounding pharmacists. And can this be the segue or the transitional thing to use instead of the chronic use of injections?
Right.
And even at pushing some of the maximum dose limitations, especially in somebody who carries, a lot of extra weight, they're much, much healthier without that. But there's very little data on somebody doing this for 10 years.
Right.
And is the sublingual dosage form an option for somebody to maybe maintain the weight loss that they've experienced without an excessive dose, or a different delivery system?
Right.
Just like changing that injection site gave us a different outcome. Changing how it's delivered, do we get a different outcome? Or do we allow people to maintain the weight loss that they've experienced because they're really much better off for it in maybe a less invasive way? They're not injecting it. The dose isn't as near as high in what we're talking about. And is that an option so that their maintenance of the weight loss that they have is a totally different delivery system?
Well, and by the time that they've hit that max dose on the injectables, that's a steady state, and we're not having to maintain that. And it's like you said, we can get rid of the needles. The steady state isn't going to drop off as precipitously either.
Right. And we've talked a fair amount about steady state in our pharmacy world because the drug has a very long half-life, but it takes quite a while to get to a steady state.
Right.
And if you're going to use it sublingually in a suspension like this under the tongue, or a lot of people are having their patients put it just below the inside of the lip, and you have to hold it for a fair amount of time, 90 seconds. I have a pharmacist friend who says, I keep it in my mouth for 10 minutes. I just squirt it in my mouth and I just forget about it. So it's different. And I think the option of that different delivery system leads us down a path of how effective is it? How long does it take to get to a steady state? Right. So people may actually, in my mind, I'm thinking if somebody's on an injectable and they really want to stop it, don't cold turkey.
Right.
Your body's going to be very confused. Peptides occur naturally in our system. So we've suppressed the natural production of these peptides. So we need to transition. So thinking out loud, do we gradually lower their injectable dose and gradually introduce an under the tongue dose? And we eventually cross over that's their maintenance. So it's all speculation.
My other thought process with coming off of the medication or weaning off of the medication, you already spoke to it. Do we ever actually get off the medication?
Right.
Maybe, maybe not. Again, this is risk-benefit analysis. Long-term data is still coming out. My other thought process is by the time the patients have hit their goal weight, they've instilled these lifestyle changes. They've instilled
hopefully.
Well, okay, right. Again, as long as they're under the advisement and monitoring of a healthcare professional, the hopeful and, well, for me, if my patients, they're not going to get the prescription if they don't show up. That's a big thing. And so that's the hope of, yes, we need to allow the peptides to occur naturally again, but hopefully by then we'll have the patients understand this is what they should be consuming. This is how much they should be working out, and so on and so forth. So we've got a lifestyle built in, so they don't just gain it all back.
What's really a lot of fun for, I think, the two of us is these are new and there's a lot to learn. And doing it correctly, because I think there's a lot of these drugs being administered incorrectly. The right people aren't dispensing them, and people aren't getting the right information. I firmly believe it is a prescription drug. It needs to be prescribed. I'm not sure that's always the case. Which
is likely where we're getting a lot of the horror stories and why people are putting it on blast on the negativity behind it.
I think you're exactly right. But then just the introduction of a new delivery system, and we're talking about this being used for lots of other types of medications as well.
Right.
And because the base is fairly remarkable. For it to deliver a drug like semaglutide with a high molecular weight like this, I would have said a year ago that's impossible to do. Insulin was tried to be they were trying to manufacture it into a nasal spray at one point in time years ago. It doesn't work. It doesn't cross that doesn't cross the mucosal tissue. Insulin's a big molecule. But I think the base that we've been exposed to and have access to is really, really cool.
Yeah, it will be interesting to see what the next few years bring in the compounding world. What can be done.
Yep. Anything else?
Those were the big things that I wanted to talk about. I'm excited.
I guess the other thing that I would mention is the injectables are expensive. Again, sometimes insurance don't pay for them. As we use our formulas for pricing from the compounding lab, we're seeing that, again, depending on the dose, but initially these are a fair amount less expensive than what people are paying for these manufactured injectable drugs. So
significantly
I think it's going to some people don't have the ability to use these GLP-1s because they can't afford the way it's being administered now. This may open the realm of possibility for them that it can be affordable. So we're pretty pleased that we might be able to help a whole lot more people.
It's a very exciting time.